right, good morning, everyone, and welcome to the combined grand rounds of general surgery and otolaryngology head and neck. So it's truly an honor, a privilege to introduce to you a colleague, a friend, and a mentor, Dr. Ashok Shah, who's probably one of the most renowned, internationally renowned thyroid surgeons there is. In fact, I think the new ATA guidelines that have come out recently have occurred largely as a result of Dr. Shah's work over the past few decades, which he's been preaching for a while. So I'm sure you're glad to see so many of these guidelines have changed recently. So Dr. Shah is currently an attending surgeon at Memorial Sloan Kettering, where he also holds the Jatin Shah Endowed Professorship, and he's a professor of surgery at Cornell University. Dr. Shah grew up in India and went to med school in Baroda, and then did his training at Tata Memorial Hospital, which is one of the largest cancer hospitals in India. He then moved to the United States in 1975 and started his training at Downstate in New York at that time, followed by a fellowship in head and neck surgical oncology at Memorial Sloan Kettering. And then he moved back, I think, to Downstate on faculty there in 1982 and quickly rose through the ranks in less than 10 years to full professor. During that time, he was also chief at the VA for a couple of years at the Brooklyn VA. And then Sloan Kettering recruited him back, and he's been at Sloan Kettering ever since then. So I think Dr. Shah, when he sent me his CV, was like 300 pages. He's had 600 publications, 462 peer-reviewed publications. But I think one of his really amazing qualities is his ability to teach. And he's consistently won the Best Teacher Award at Downstate, at Memorial Sloan Kettering. I've had the personal experience of actually organizing a poster chair session for one of our national meetings, where we had people following different poster leaders in various groups. And I went down to check on how it was going at this international meeting. And all the people had left all their groups, and suddenly there was one group that had everyone following. And I looked, and sure enough, it was Dr. Shah. People had left their groups to follow him because they heard a lot of laughter and fun during that group. He is also both nationally and internationally a leader and president of a number of local and national societies. So he's been president of the New York Surgical Society in, I want to say 1998. The two societies, the General Surgery Head and Neck Society and the Otolaryngology Head and Neck Society, merged to form the current American Head and Neck Society. And you can imagine two strong personalities merging was not easy. And it's only because Dr. Shah was co-president that year, and with his magnanimous and all-inclusive personality, I think the merger has worked so well. He's also recently been the president of the Endocrine Society. He has had a number of awards, the American Academy Distinguished Service Award. He's been in charge of the TAC, which is the fellowship program, and received their Distinguished Service Award for putting together the American Head and Neck Fellowship curriculum and approving various fellowships. And he's on the editorial board of many journals, including Journal of Surgical Oncology, Journal of Clinical Oncology. As a result of his international recognition, many countries have given him honorary membership in their societies. The Brazilian Society, Korean Society, and I can keep naming the number of international organizations. He was recently also elected to the American Surgical Association and delivered the Hayes-Martin lecture, and I know some of us who were at that meeting heard that lecture, and it was amazing. So Dr. Shah, I think, has dedicated his professional career to the training of many medical students and residents, and a preceptorship program at Cornell University has been established recently thanks to him. So once again, I want to welcome him. I invited him in February. I said, you'll need a break from that winter weather in New York, but he brought it with him. And I also thought with it being a long weekend, he could have fun in Mardi Gras. His son, Manish, is one of our residents here, and I thought it would be a good time to spend Mardi Gras weekend, but I think the weather didn't permit that. So.
I didn't bring it.
Thank you.
Thank you very much, Chirian. It's great to be here. Thank you for that generous and very kind introduction. Normally, I would have said, wish my wife was here. Nowadays, I say, wish my mother-in-law was here. You know, she's a tough cookie, but it's okay. So whenever you give a grand round, especially invited grand round, the first slide is the most critical slide. This is a slide with the institution, something very attractive name, you know, triumph over Butchery. Everybody wants to know what is going on here. The rest of the talk is generally 10 years old, okay? So whenever you see a visiting professor, you say, I heard this talk before. So the second slide is always the institution you come from. You always show your institution. This is a Sloan Kettering. This is a new research building. We have spent $1 billion here. When I left, the president told me, you are going to Shreveport. There are many very rich surgeons. Collect the donations. American Express, Visa, cash, anything is acceptable. Okay? So I'll be happy to take some money home. This is a new operating room, outpatient operating room. So we always show this as what we are doing at Sloan Kettering. Now this is probably the most important slide, and the words triumph and Butchery come through this. This is the World Trade Center. Many of you probably did visit that place. At the top of the observatory, there was a statement, New York, the nation's thyroid gland. Shreveport may be parathyroid, but New York will always be thyroid. Remember that, okay? So this was perfectly okay. Things changed, as you know very well, after 9/11, and this is the triumph. This is the new Freedom Tower, which is really a monumental piece of work and something that we will remember for the rest of our lives, what happened on 9/11. So why do we talk about triumph over Butchery? Because Samuel Gross, one of the foremost surgeon in the United States, made this statement almost 150 years back. He called thyroid surgery a horrid butchery. And he went on to say, no honest and sensible surgeon will ever engage in thyroid surgery. I love this statement. You know why? Because he was absolutely wrong. And it is very, you know, one of the joys of being a surgeon is to be able to criticize another surgeon, right? That's what we do in the M&M. The whole idea of M&M is not to learn something, but to criticize somebody else, okay? And the easy way to criticize is when the person is not in the audience, and the greatest way is when he's dead. So Samuel Gross cannot do anything up to me, whatever I say about him. Now the credit goes to Theodore Coker, who revolutionized the thyroid surgery worldwide. The mortality which was reported by Bill Roth as 40%, he reduced to less than 0.5%. Amazing. And he was the first surgeon ever to win Nobel Prize, not only for perfecting the technique of thyroid surgery, but more importantly, the physiology of thyroid surgery. So credit goes to him. Who brought it to United States? William Halstead, the person who established Johns Hopkins. And he made this statement. This is probably the greatest statement you will ever read in thyroid surgery. The extirpation of thyroid gland represents the supreme triumph of surgeon's art. This is great, you know. I mean, you cannot have any other better statement for thyroid surgery. Now, whenever I give this talk in general surgery, there is always one colorectal surgeon who gets up and says, the supreme triumph is not thyroidectomy, it's hemorrhoidectomy. It hurts. I think that is right, you know, probably he's correct, you know. Okay, so what has changed? We have come a long way from Theodore Coker to Woong Chung from Korea, and we'll talk a little more his contributions in relation to thyroid surgery. So we have come from Vienna to Seoul or from Austria to Korea. So I always like to show this slide. This is my favorite slide. I always like to see what is going on in the PubMed. Every 2 hours, there is one new paper in the literature on thyroid disease. By the time you sit down for late lunch, there will be one new paper in the literature on thyroid cancer. It is the same paper I have been writing again and again and again, And I have a great, attribute. I write sometimes in English, which is half the time. The remaining time I write it in Hindi. So once it is written in Hindi, it gets into one of the PubMed, or you can write in Korean, German, Russian, you will get it into the PubMed. If you don't know where to publish, ask me. I'll find a journal for you. Don't worry about it. Now this is perfectly okay. We have been doing this for many years. What has changed is this Google search. Every time the patient has a problem, they don't go to the doctor first. They go to the Google first. So there are 20 million sites. Every patient who comes has read almost 19 million. It takes them 333 years to read those sites. But they come prepared. And when they come to see me, now in the olden time it was about 20 minutes, 30 minutes. Now it is 2 hours. I feel that I'm going for American Board of Surgery exam. They keep asking me questions. They bring all the reprints. They're all highlighted, And they ask me, the last question they asked me, but you said like this 30 years back, what changed? The answer was very simple. 30 years back I was dumb, now I'm smart. So they don't, and I have changed the thyroid consultation word. It is not consultation, it is confrontation. And this is what happens all the time. The last patient I saw before I left New York, I told her, I cannot charge you. You taught me so much today, Now this will be very helpful when I give a grand round in Shreveport. So this is my favorite slide. Only 20% of you will remember 20% of what I said 20 minutes after the talk. So I have another talk at 12 o'clock. You would have forgotten everything what I have said today. So why do we talk about thyroid so much? If you look at all the human cancers, there is one cancer with the most rapid rise, and that is thyroid cancer. You can see here from 8,000 or 7,000, now we see about 60,000. Almost 5-fold rise in thyroid cancer. And this is not only in the United States, it's all over the world. Now what is interesting is, majority of these cancers are small cancers, below 2 centimeters. What's the survival in that group? 99.5%. It will be very difficult to find an incidental microcarcinoma and the patient dying of thyroid cancer. That's a rarity. If that is happening, there is something wrong with the pathology. The tumor was more aggressive, you didn't appreciate it. Now whenever we talk about thyroid surgery, what are the issues? Keep in mind, we always talk, let's just do a total thyroidectomy, perfectly okay. But there are complications and side effects. You have to be on lifetime thyroid medication. A young woman who is taking thyroid medication for the rest of her life, believe me, the life is not the same. It's miserable. They just don't get adopted to the medication. The natural hormones versus artificial hormones, there is a big difference. The quality of life changes quite a bit, and keep in mind there is always a cost concerns over the treatment. Now one of the commonest problems we see at Sloan Kettering is a PET incidentaloma. If you call my office or any surgical oncologist at Memorial, you won't get the appointment. They'll say, go and get a PET scan and then come and see us. The PET scan is always in the first floor, so you walk, get a PET scan, come to my office. When they come to my office, there is a PET incidentaloma. This is the hypermetabolic right thyroid nodule. What do we do about it? Tell the patient, go home, don't worry about it, take care of your breast cancer, or take care of your other tumors, or I want to do something more about this. And we invested a lot of our time reviewing our experience with PET incidentaloma. And whenever you are in the operating room, you learn a lot from your residents and fellows. And I always discuss something at the time of surgery. You can discuss about Trump, you can discuss about Obama, you can discuss about North Korea, but something that will perpetuate or stimulate everybody. So we came up with this term, PET-associated incidental neoplasm. It is also called as pain. And I was so happy when this demonic pain, and we sold it to the Journal of American College of Surgeons. You can fool a lot of people quite often. It's not difficult. You did it. So what was the message? The message was, is it focal or diffuse? If it is diffuse, don't worry too much. It's probably Hashimoto, nodular goiter, etc. If it is unifocal, the risk of cancer is about 30 to 40%. So the bottom line is, don't neglect PET incidentaloma. That's the bottom line. And large number of these are about 50% malignant, and a lot of them are aggressive cancer, poorly differentiated Hurthal cell or insular tumors. Now this slide is probably the most important slide of my talk. This gives you the perception of thyroid cancer and the biological behavior of thyroid cancer, which is so unique to thyroid cancer. And I made this slide several years back. I used the word unique human neoplasm. I didn't put the word cancer. Cancer is scary. Neoplasm is not scary. So tell the patient you have thyroid neoplasm, she will be very happy. So what are the features about this? Age is a very important prognostic factor. We used to cut off the age of 45, now it is 55. We have changed the age limit as a good cancer versus bad cancer as 55 today. The multicentric cancer or microscopic cancer is very common. If you examine everybody in this room today, I can tell you 20% of us are living happily with thyroid nodule, and 5% of us have microscopic thyroid cancer. Make sure nobody does an ultrasound on you, because if you get ultrasound, you will find something, you will be in the operating room soon. So live without doing any further investigation. As a matter of fact, the new guidelines by the United States Task Force for Prevention says, don't examine your neck. Now that is probably a little too pushy. Don't do the routine ultrasound, that's what they mean. But examine the neck for other problems. So I think this is a major change. The microscopic cancer is very common. Now this is most important. The nodal metastasis in thyroid cancer does not have a major prognostic impact. You take any human cancer, whether it is a pancreatic cancer, lung cancer, breast cancer, nodal metastasis, survival goes down, not in thyroid cancer. So there is something unique about thyroid tumors or thyroid neoplasm that is different than other human cancers. We look at the thyroid cancer at Memorial as a good, bad, and ugly, the low, intermediate, and high risk group. Now this is very critical in analyzing the thyroid cancer. The day the thyroid patient walks in your office with cancer, you know, you can project his lifetime survival. If I have thyroid cancer today, the possibility of something happening to me is very small. Because we know right on day one how big the tumor is, what is the histology, did it go to the surrounding areas, you can tell exactly what is going to happen to this patient. We reviewed our large experience. I won't go in the detail, this has been published, but just want to show you some of the prognostic factors. Let's look at the age. Age below 45. The survival is 99%. You are above 45, the survival goes down to 84%. So age is a very important prognostic factor. The size of the tumor, more than 4 centimeters, not good. Less than 4 centimeters, which is a common presentation of thyroid cancer, they do remarkably well. The sex does not have a major impact. Probably female do a little better than male. They do that all the time in life, so there is nothing wrong in it. The papillary cancer, they do much better than follicular cancer. So these prognostic factors, on day one on clinical exam, you know who is going to do well and who is not going to do well. The nodal status does not have a major impact. This is very critical, the extrathyroidal extension. What do we mean by that? When the tumor has come out of the thyroid gland, invading surrounding structures like trachea, esophagus, recurrent laryngeal nerve, the survival goes down. Why? Because we do not appreciate it and don't do the best cancer operation. The key in the management of thyroid cancer is, on day one, do the best cancer operation. You got to get R0 resection. If you do that, the survival is almost normal like any other human being. So that is the key in management of thyroid cancer. You can see here the extrathyroidal extension, If there is extrathyroidal extension, there is a higher incidence of recurrence. And the last is a distant metastasis, which is not good in older people, but in young kids, distant metastasis does not have a major impact. If you have a 10-year-old child with pulmonary metastasis, that child is probably going to live normal life. Again, a different biology of thyroid cancer. And based on this, we at Memorial looked at our entire database, the low-risk cancer. The survival in this group is 99 to 100%. So what is a low-risk? Young patient with small tumor, less than 4 centimeters, low-grade histology, and no extrathyroidal extension. That's a low risk. The survival is 99 to 100%. What is a high risk? Older patient, larger tumor, extrathyroidal extension, or high-grade histology. What is the survival? 71%. So clinically, you can tell what is a good thyroid cancer, what is a bad thyroid cancer. What is intermediate? Young patient with bad cancer or old patient with good cancer. If I have 3 centimeter thyroid cancer, the possibility of my dying of that cancer is very little. I'll probably live normal life. So we can now look at our thyroid cancer into the low, high, and intermediate and high risk group, or the good, bad, and ugly. Now, one of the major debate goes around the world is in a low risk group, what do we do? Lobectomy or total thyroidectomy? We've been fighting about this for the last 100 years. We'll continue to fight about it. If we don't fight about it, we'll find another issue. One of the important aspects of academic surgery is you must have a debatable issue. Otherwise, nobody will invite you. So you always come up with one more issue. So this issue is resolved, lobectomy versus total thyroidectomy. Now we are debating about the prophylactic neck dissection, which we never talked 10 years back. So we always come up with a new issue in academic surgery. Now if you look at this more critically, whether you do a lobectomy or total thyroidectomy in the low risk patient, the survival curve is the same, 99 to 100%. You walk on the streets of New York City for 20 years, your average survival is 98%. There is a 2% chance that one of the Indian cabbie will kill you. Okay? Not thyroid cancer. So this is very common in New York. Now this statement is very critical. It literally resolves all the debates we have about extent of thyroidectomy. And this is very good not only for thyroid, for any debate. The fact that you can do a good total thyroidectomy safely does not necessarily mean it is indicated in all patients with thyroid cancer. An operation not worth doing is not worth doing well. You can use it in colectomy, you can use it in pancreatectomy or hepatectomy, you can use anywhere. But this is the golden truth of thyroid surgery. Now, I'm not going to go in the details of these surgical paradigms. Cherian mentioned we had a major contribution in the recent staging and guidelines of American Thyroid Association. We developed the prognostic factors at Memorial, the risk groups. We understood the locally aggressive thyroid cancer. What does it mean by extrathyroidal extension? We also talked about the minimally and widely invasive thyroid cancer. When you get a report from the pathologist, follicular carcinoma, the first question you ask them, is it minimally invasive or widely invasive? If it is minimally invasive, we call it non-threatening cancer. And the survival in that group is 99 or 100%. You can't do any better than that in any human cancer. But if it is widely invasive, extrathyroidal extension, major vascular invasion, the survival goes down to almost 75%. The age group, we changed it to 55 because we had the data from all around the world that 55 was a better cutoff. The lobectomy, the debate about lobectomy versus total thyroidectomy is now resolved. The American Thyroid Association has accepted lobectomy up to 4 centimeters. It's a major change in the culture and management of thyroid cancer, which we did not have before. There is no role for a prophylactic neck dissection. The more prophylactic neck dissections you do, the more complications you see. And the worst complication is permanent hypoparathyroidism. Again, how often we do completion thyroidectomy? Very rarely. Unless the tumor is really aggressive or the final pathology report comes back as poorly differentiated. And we will talk a little more about microcarcinoma later in my talk in the afternoon, but there is a lot of interest now in treating microcarcinoma by observation. Let's say your daughter or your sister has incidental thyroid cancer. She goes for some neck evaluation, somebody does the ultrasound, and there is a 5 millimeter papillary cancer. You want her to have thyroid surgery? She can live very happily with that 5 millimeter thyroid cancer. Japanese have done that. At Memorial, we have got more than 300 patients. We're not operating on them. We're just getting ultrasound every year. And as long as the 5 millimeter does not change into 15, we're quite happy. Now, it requires a lot of understanding on the part of the patient and the family. It is very difficult to tell the patient that you have cancer, but I don't want to operate on you. But if you explain them the entire biology, tell them that the 5% of the American population is living happily with thyroid cancer. You are one of the unfortunate whose cancer was found, but my daughter has cancer, it was not found. If you convince to them, I think they will accept that, but it takes a lot of convincing both from the surgeon and endocrinologist. Keep in mind, the complications of thyroid surgery are directly proportional to the extent of thyroidectomy and inversely proportional to the surgeon experience. And this is very true not only for thyroid but everywhere else. And the second line, which is more important, when you hear a surgeon talking about the number of performed cases, divide by 2. And when he talks about the complications, multiply by 2. Right? We have a very short memory about our complications. We forget them very fast. That's good because we don't remember them and we don't worry about them. But we have a tendency, we're like politicians, we promise and we forget next day. So this is the same true with thyroid. Now the worst complication of thyroid surgery, nerve injury, etc. is there. But to me, the lifetime complication is permanent hypoparathyroidism. Imagine you have got one of the resident with permanent hypoparathyroidism. She is going to suffer for the rest of her life. Every day she will have to check her calcium. When she does not feel well, she goes to the emergency room. And if you are the attending surgeon, believe me, your life is miserable. She will keep calling you all the time. She needs to know your cell phone number, in which part of the world you are, because there is no choice. I have created this complication, I have to live with it. Let the punishment fit the crime. This is so important in thyroid surgery. This is a statement made by Blake Cady from Leahy Clinic, and this is so true when it comes to thyroid surgery. Now the new ATA guidelines, I won't go in the details, but just wanted to make reference to some of them. There is a lot of interest in markers, the Afirma, which is run by Veracyte company, or ThyroSeq by CBL lab from University of Pittsburgh. Let me see if I can go back. Okay, sorry for that. There is a lot of interest now not to do the FNA unless the nodule or thyroid mass is strongly suspicious. We never had that. We had always the philosophy, thyroid nodule, do a needle biopsy. But the current guidelines say if radiologically it is not suspicious, don't do the needle biopsy. Just monitor the patient. This is a major paradigm shift in the management of thyroid nodules, thyroid cancer, that we can observe these patients. There is more emphasis on quality of life. There is, we talked about the extent of thyroidectomy, selective nodal dissection, and this is the last very important. At one time, there was a knee-jerk reflex in United States. Thyroid cancer, total thyroidectomy, radioactive iodine. Change quite a bit. The most prominent endocrinologists now don't want to give radioactive iodine unless the tumor is really aggressive, or you can feel that it will make some impact on the patient's long-term outcome. Keep in mind, radioactive iodine has some complications, sialadenitis, chronic sialadenitis, and there is a higher incidence of developing second primary tumors, such as parotid cancer, parathyroid tumors, and leukemia. There's no doubt about that, and the data all around the world shows that very vividly. A lot of interest now in the ATA guidelines about voice evaluation. We never paid attention to the voice during thyroid surgery. I think now looking at the vocal cords before and after is almost a routine. It would be very rare we would operate without reviewing the vocal cords. CT with contrast, there was a lot of sentiments against it, because when you give the contrast dye, it delays radioactive iodine, but it delays only for a couple of months. And nobody gets radioactive iodine for 2 to 3 months after surgery. So if you can get better evaluation of the extent of the disease, I think it is very important to use CT scan. We talked about the observation and surveillance, and the biology and risk group interpretation is very important in the management of thyroid cancer. Now, this is a new staging system. This is the H staging system, which has changed quite a bit. And you can see here the major important points. The age classification is now 55. The T classification has changed now. The tumors which are invading the surrounding structures are now called as T3B. It used to be called T4. And N1B, which is the lateral neck nodes, is now not stage 4. I won't go in the details, but just wanted to tell you that this is the only tumor where the new staging system has downgraded the 35% of the patients. It's interesting, when I was seeing the patients in December, they will ask me, what is my stage? And I would tell, today you are stage 3, but wait for the new year, you will be stage 2. And they couldn't understand. They thought that I was stupid. I mean, most of the time I am. But still, I had to convince them that the staging system is changing. And this is the only tumor, and we'll talk a little bit in the afternoon about the new nomenclature of thyroid tumor called as NIFP, non-invasive follicular tumor with papillary-like nuclear structures. The encapsulated follicular tumor, which used to be called follicular carcinoma, is now called as NIFP. It is considered as a precancerous. The only pathology where now we are changing from what was called cancer to call it precancerous now. So again, the biology of thyroid cancer is very critical when we make important decisions. And this is our own data at Memorial. You can see here with the stage migration. You can see here the stage 1 increase because the rest of the other tumors, the 8th edition, the stage 3 and 4 is now downgraded to stage 1 and 2. So this is a major impact. About 30% of our patients are downgraded to earlier stage. Very important because we now understand the biology of thyroid cancer and the overall outcome. Now, occasionally you will see a patient like this. This is a patient who had exploration in New Jersey. I don't know what is between New York and New Jersey, but we always like to look at the neighboring state and downplay them. So this is from, I can't afford to go to New Jersey. The toll is $15, it's too much. So he had exploration at New Jersey and it comes to us. He was considered as inoperable because the surgeon made 3 centimeter incision. This man needs 30 centimeter incision, right? The most important aspect of any cancer surgery is good exposure. So he comes to us, we operated on him. He was something like 68 now. He is now 78, living very happily, only because we did the best cancer operation first time. And that is a message in any cancer surgery. Do the best cancer operation first time. A patient presenting like this, you can see here a large tumor with involvement of the recurrent laryngeal nerve, paralyzed one nerve. Any surgery to the other side is going to be dangerous. You injure the nerve on the other side, the patient will wake up with tracheostomy, major concern in taking care of this patient. So whenever you see a patient with aggressive thyroid cancer, when you see a patient like this, what do? Send them to Cherry Ann, say, hey, I have a great patient. And whenever you get a call from your colleague, and the first thing he says, I have a great patient, this is a dump, right? It doesn't want to take care of the patient, or he knows the outcome is not going to be good, or the family is very aggressive, or the last thing in New York that happens all the time, the patient is an attorney. Okay? We are so generous to give the attorneys to somebody else. I don't want to take care of them. So send the patient to the tertiary care center or send the patient to a place where the multidisciplinary approach is available. Very important. Because the care of thyroid, any cancer patient is A to Z. And that does not happen all the time unless you go to the major university center. People will take care A to C or A to B and then send the patient somewhere else, which is not right for the patient best care. This is my favorite slide. We talked about the aggressive thyroid cancer. Don't jump in the lion's cage if you don't know how to get out of it. So that patient with aggressive thyroid cancer, paralyzed vocal cord, don't jump in to take care of him if you are not willing to take care A to Z. This is very important. Sometimes the tumor may be stuck to the trachea. This is a real problem. This is the cartoon that was made by Hermes Grillo, the famous tracheal surgeon from Boston. He made enormous contributions in tracheal surgery. So what he showed was the tumor may be adherent to the trachea or just minimal tracheal invasion. You can easily resect this nicely without getting into the trachea. The survival is same as any other patient with thyroid cancer. However, stage 3 and 4 or type 3 and 4, where the tumor has gone inside the trachea or inside the lumen of the trachea, that's bad. These people will require a sleeve resection. And if you are not prepared to do that, don't operate on this patient. This patient will eventually die of the tumor growing into the trachea, obstructing the trachea. So you need to evaluate the patient very carefully when there is a tracheal invasion. Good judgment comes from experience, but in life, experience comes from bad judgment. And believe me, we as surgeons have learned more by our bad judgment. As long as you keep it open and learn from your mistakes, I think that's a key of success in thyroid surgery. Thyroid surgery is a continuum of diseases. It's amazing how in the same human organ, you have got the best human cancer, papillary carcinoma, correct? The survival is 99%. And in the same human organ, you have got anaplastic thyroid cancer, the worst of the worst human cancer. Number 99 is the same now, but it's not survival anymore, it's mortality. I have never understood how in the same human organ you have got the best of the best cancer and the worst of the worst cancer. That's my first question when I meet God. How did you do this, man? I don't know how this happens. So it goes from papillary to tall cell, then it goes to moderately differentiated, poorly differentiated, and anaplastic thyroid cancer. Now, whenever the surgeon gives a grand round, it's very important to show some histopathology, the large nuclei, nucleoli. I don't know where they are. I don't care also where they are. But thank God my pathologist put the names, Otherwise, I would have started with anaplastic. I wouldn't have known. And one of the students would have said, oh, that's not correct, The students are much smarter than the faculty most of the time. So what we learn from this continuum of diseases, the radioactive iodine avidity goes down from one end to the other end. And what is also important in last 10 years, the PET positivity goes up. And this is very important in the follow-up of these patients. These patients need to be followed with a PET scan, very important. The radioactive iodine scan won't help in this group. So what do? I'm just going to take a few minutes about the neck nodes. I won't go in the details. When the patient presents with a clinically negative neck nodes, what do? In the central compartment, we always look around. There is a debate between central compartment evaluation and clearance. We don't do clearance on everybody unless there are suspicious lymph nodes. But we always look around the trachea, the Delphian nodes, the paratracheal nodes. If they are enlarged or suspicious, we take them out. Occasionally, we get a frozen section because lymph node positivity is very common in thyroid cancer. It's also common in Hashimoto. And Hashimoto is a very common disease. So there are globular nodes near the thyroid, get a frozen section that is benign. You don't need to do anything more. If the lymph nodes are clinically palpable, we're always concerned about it. And the best operation is selective or modified neck dissection. We don't do any more berry picking, which is going and taking out a couple of lymph nodes. That's a wrong operation for thyroid cancer. So we would do a modified neck dissection in most of these patients. This is my favorite slide because I look much smarter here than in reality. But this slide will tell you the full circle in medicine. There are always full circles in medicine. And one of the full circle in thyroid cancer was we used to do a lot of elective and radical neck dissections. In the 50s and 60s, a lot of people underwent radical neck dissection. I think that was a crime in my judgment. But again, we didn't know the biology. So we realized there is no prognostic implication, only therapeutic neck dissection we do. Now what happens is when the patient comes for follow-up, in the olden days, the follow-up was very simple. I would examine them every year. They look good. There's nothing palpable. Go home. You're doing great. We'll see you next year. Now, before they come to my office, they get their thyroglobulin. They get the ultrasound, they find a 5 millimeter recurrence, they come and tell me, oh, you failed, the cancer has come back. And the answer is, you should not have had the ultrasound, you should not have had the thyroglobulin, but that happens. Once that happens, they come back for neck dissection. This is a full circle. And we need to break that. How do we break that? By explaining and understanding the biology of thyroid cancer. That's the bottom line. We need to break this circle. Now, what has happened is, we are doing more and more follow-up ultrasounds. We are finding more and more recurrent cancers. Keep in mind, every recurrent thyroid cancer does not need surgery or does not need treatment. Just suppress them, they will live happily. They will outlive you. I always tell the young patients, you will always outlive treating surgeon. So I always tell the young patients, find the youngest surgeon on the staff, because you are going to live 75 years just like him. So is this a scientific reality, recurrent thyroid cancer, or are we the victim of technology? I think we are true victims of technology when it comes to thyroid cancer. We are finding more and more of them, more and more recurrences, more and more distant metastases, which has no impact on the overall outcome of the patient or survival of the patient. In spite of the high incidence of thyroid cancer, our survival has remained the same, 99%. That has not changed. The PET scan is very important. I think now we use it in all aggressive thyroid cancer or medullary cancer or anaplastic thyroid cancer. We showed that the PET positive patients don't do as well compared to PET negative. You can see here the PET positive patients don't do well. We also showed that the number of lesions, if the number of lesions is more than 10, they don't do very well. We also showed that the standard uptake value, if it is more than 13, they don't do remarkably well. So these are some of the nuances in the management of thyroid cancer. There's a lot of interest now in looking at the PET scan and using targeted therapies, especially based on the molecular biology. And if you go to the website of US government, you will find number of clinical trials in thyroid cancer. Amazing. And for medullary, for anaplastic, because those are more aggressive cancers, and for recurrent thyroid cancer. There are a variety of drugs that have come up. You can see here the standard chemotherapy, and now there are molecular-based chemotherapy, especially the sorafenib, pazopanib. There are 4 drugs which are now approved by FDA for recurrent thyroid cancer. And at Memorial, we have a SPORE on thyroid. We have clinical trials. Variety of drugs are used: sorafenib, vandetanib, selumetinib, pazopanib. And one day, I'm sure there will be Ashok-nib. I'm sure that will come up soon, and I'm sure that, again, just to give you the idea that there are a lot of new trials, and this is where we need to invest our time and energy, and not the standard debate on thyroid cancer. I'm just going to take 5 minutes and close. We are in search of ideal operation or ideal surgical procedure since mid-16th century. I think Coker brought it to the daylight, to the nuances of reducing the mortality, but we are still looking for what is the ideal operation. We always use the harmonic ligature. There's a lot of debate about nerve monitor, whether the nerve monitor really reduces the nerve injury or it just tells you in the operating room something went wrong. We don't know that. All the meta-analysis around the world have shown that the nerve monitor has not been able to reduce the overall nerve injury, which is in the range of 1 to 2%. Endoscopic thyroidectomy, a lot of interest in Italy, a lot of interest in Korea, Japan, and the new interest in robotic thyroidectomy, robotic transaxillary thyroidectomy, what is called as BABA approach. You make incision in the axilla, another incision around the nipple, and use the robotic instruments to take the thyroid out. Too complicated, untrustworthy in my judgment, needs a lot of experience, lot of learning curve, and you get a lot of complications during your learning curve. I'm still very unclear what is the meaning of minimally invasive thyroid surgery. I made 3 centimeter incision, my colleague made 4 centimeter, means I am a minimally invasive surgeon. I sent the patient home that night, I am a minimally invasive thyroid surgeon. I did a lobectomy, minimally invasive. I don't know the meaning of the minimally invasive. And the surgeons who use robotic or the transoral approach, they call themselves minimally invasive. It's a misnomer. They are maximally invasive. But they will always tell the patient, I am a minimally invasive surgeon. There's a lot of interest in robotics, transaxillary, face lift approach, making an incision in the posterior hairline, a lot of interest in that. And the current interest around the world is transoral or translabial approach. That is popular in Thailand. I don't know when it will pick up in the United States, but there is considerable interest in these nuances because now we have a technology. And keep in mind, just because you have a technology, you don't need to use it. You know, the old hammer and nail phenomenon, I think we need to bring it back in thyroid surgery. Endoscopic surgery, is it minimally invasive or is it maximally expensive? Probably maximally expensive. Now, I show this slide just to tell you that there is all these endoscopic procedures have a long learning curve. The average experience to do a good robotic surgery is 50 cases. Otherwise, your complication rate is very high. Now, in airline industry, have you ever asked the pilot, sir, are you on your learning curve? How come in surgery we accept it? We say, yeah, I'm on my learning curve. Or we are very proud. Today I did the 40th thyroidectomy. My learning curve is over. I had a lot of complications in the learning curve. Now I'm a better surgeon. Does the pilot say that any time? Why don't we use the analogy of the airline industry in surgery? I think that's very critical and very important. This is the axillary incision. You make an incision in the axilla. There is another incision around the nipple. You go in. I mean, this is too complex for me. What is the advantage of this? The only advantage of this is the girl doesn't get an incision in the neck. And I can tell you from my own experience, no American patient is upset about an incision in the neck. As a matter of fact, she goes to the party and shows, look, this is Shah's incision. And somebody else comes and says, this is Thomas's incision. They are very proud about it. One day, I'm pretty sure, before I die, there will be transrectal thyroidectomy. I'm sure this will happen. And if it does not happen in human beings, you can do it in cadavers. They don't complain. Or the best for academic surgery is pigs. You take the pigs, they don't complain. I love them very much. Modern technology will turn a third-class surgeon into a second-class one, but will never turn a second-class surgeon into first-class. And our job is always to be a first-class surgeon. To be a good endoscopic surgeon, one needs to be a better open surgeon. And I think that's the principle of not only thyroid surgery, any surgery. The decision is more important than incision. And that is what we need to learn in our academic training and in the fellowship. When technology is a master, remember, the result is generally a disaster. Let me just spend 1 minute here and I'll conclude. If you look at the nerve injuries and the complications, the parathyroid, recurrent laryngeal nerve injury, there is one nerve which we don't talk much about, and that is the superior laryngeal nerve. That's the nerve which makes the vocal cord tight. That's how you yell at your spouse, right? Both ways. Or yell at your junior resident. Or the most important is sing and be a lecturer or a professor. This is the nerve called as Amelita Galli-Curci nerve. She was the greatest soprano in the United States, had thyroid surgery in 1935. Never sang again. I don't know, I was not there. I didn't look at her vocal cords, so I don't know what happened. But that nerve, superior laryngeal nerve, is called as Amelita Galli-Curci nerve because she could never sing after the thyroid surgery. Just one word about, this is my favorite syndrome. This is what I call as post-thyroidectomy central compartment syndrome, which is caused by scarring and fibrosis around the cricopharyngeal area. It gives the vague symptoms of choking, something stuck in my throat. Those symptoms take a long time to improve. And they happen in any human surgery. Whether you do the hernia, they feel something is stuck there or something is bothering me, the same in the neck. But these symptoms can be very difficult for patients to understand and accept. Even though we have made enormous progress in thyroid surgery, we have understood the biology and we have gone to a new level, I don't think we have made any progress in last 50 years in anaplastic thyroid cancer. The second guidelines will be coming up in next year or so. I am on the guideline committee, and we have not made any progress. We are writing the same papers again and again. We are writing again and again that the 5-year survival is still 5%, and most of the people are dead in 3 months. This is a patient, this is a surgical syndrome. Friday night, I saw this patient around 5 o'clock. Why Friday evening? Why couldn't she come on Thursday? I had no idea. But she comes on Friday, the evening is ruined. Within 10 minutes, she gets intubated with the airway distress. This is the most difficult problem you will ever face in thyroid surgery, the anaplastic thyroid cancer, because you don't know what to do about this patient. Do you let her go? Just give her morphine? Do you do the tracheostomy? While doing the tracheostomy, will she die on the operating table? A real problem. These are difficult problems in thyroid surgery. I hope in last 45 minutes I have not confused you. But if I did confuse you, that means I have done a good job. You know why? Because then I have to come back again to clear up the confusion I left with. Right? That's the principle of surgery. So I just want to conclude by showing the thyroid cancer comes in 3 forms: the good, bad, and ugly, the low, intermediate, and high risk group. It is this group where we need to have some inventions or some involvement of the cooperative groups, cooperative studies. The low risk group, the survival is excellent, 99%. What you need in the thyroid surgery is a center of excellence, which is what we call, I like to call, endocrine armamentarium. The surgeon, the thyroid surgeon, the radiologist, the pathologist, all these different specialties need to work together to bring up the best care of patients with thyroid cancer. And you need a multidisciplinary group. This is our own multidisciplinary group. Dr. Shah is here, I am here. We have got our endocrinologist, who is probably the most important person because he has a better connection with the patient. He is going to follow the patient for the rest of his life. Our endocrinologists are very honest. They will tell the patient, Dr. Shah has cured you, but I am going to take the credit for the rest of my life. At least they are honest about it. There are 3 stages in the life of a surgeon. The first 10 years you learn how to operate. That's the stage 1. The next 10 years you learn when to operate. And the last 10 years when the hair are gray or there are no hair, you learn when not to operate. These are the 3 stages of a life of a surgeon. In 30 years, that is what you do. And there is a 4th stage which puts you the smartest surgeon in the world. And that is when to dump the patient to somebody else. If you know that, that means you know your limitations. I think you will help the patient very well. You can always use my 800 number. If you have any questions, feel free to call me. The Obamacare, when it was prevalent, I used to have this number. Actually, many people call this number. They did not realize this was a joke. So anyway, I just want to conclude here. I'm going to take 1 more minute because I see a lot of young faces here, residents and fellows. And they need to get a message how you want to be a successful surgeon. This is a small truth to make life 100%. We all want to make our life 100%. Why did you come to surgery? Because you wanted to make your life 100%. Can you do that? Yes. I'm going to put you to work a little bit. This will take only 1 minute. If you use the numbers A to Z, 1 to 26, you have to do a little arithmetic. You want that 100%. Remember that. That's what the goal of your life is. So let's look. What can we do? Hard work, right? That's the bottom line of being a surgical resident. Comes to 98%. You've done well, but you're still not that 100%. Keep in mind, this is only for the surgical residents, how they want to be 100%. Let's look. Knowledge, no doubt, 96%, not 100% still. Love, 54%. Don't worry, your 5 years are gone, so forget about it. Luck, we always talk about this, right? Luck. Wish I was lucky or my colleague was lucky, 47%. Then what makes 100%? And that's the most important. Money? No, 72%. Leadership? President of this, president of that, president of the resident committee, 89%. We're still looking for that 100%. And if you want to make that 100% for the surgical residents, what you need is attitude. Attitude, ladies and gentlemen, comes to 100% exactly. And if you have that attitude, you will make life very easy, you will enjoy, and you will have the passion about what you do in your academic surgery. Thank you very much.
Dr. Shah, that was awesome. Do we have any questions from the audience?
Yes, sir.
Under what circumstance would you consider surgery for recurrent thyroid cancer?
Good question. So there is a whole talk on that. I will come again, but I'm going to give you a 2-minute answer. Recurrent thyroid cancer divided into 3 groups. The local recurrence, which is in the thyroid bed, always a surgical problem, because it will eventually go into the nerve, it will go into the trachea, and it will cause central compartment death. So always surgical problem, as long as you can dissect it nicely. The nodal recurrence happens more than 20%. The nodes which are in the level 3 and 4, you can monitor. The nodes which are in the paratracheal area, we would be more aggressive with the understanding that the risk of nerve injury is high. So those are the two. The distant recurrence, rarely a surgical problem, unless there is a pressure phenomenon, the hip problem or the spine problem, or there is a cord compression, you do the surgery. But otherwise, a very standard way to look at the cancer. But we have now a philosophy not to operate on anything below 1 centimeter. Number 1, you cannot find it. Number 2, you will injure the nerve more often. And number 3, even if you remove that disease, just let's go back to the original. Who recurs? Somebody with 10 positive nodes will recur because there is an 11th node missing. Okay, you found the 11th node, you go back to take it out, there is a 12th node somewhere else. It will come up in another 6 months, 8 months. So watchful observational approach is very appropriate. We have more than 250 patients with recurrent thyroid cancer just monitored. And the good thing about well-differentiated thyroid cancer, they don't grow rapidly. You don't miss the boat in those patients. So just monitor them.
What did you do Friday night? You showed us the problem. You didn't show us.
Oh yes, that's a great question. Okay, so this lady came, she's a nurse, she was 65, with 3 daughters. One is a doctor. So my Friday night was shot. When I saw her, we had to get her to the emergency room to intubate. She had a huge tumor, anaplastic cancer. I got a core biopsy. The core biopsy, we went for frozen section, anaplastic. I mean, you could smell anaplastic. So now the question comes, do I leave her alone in ICU on a ventilator? Or do I tell the family she's going to die and be prepared, I'll give her morphine, get her extubated at your time and let her die? Or bring her to the operating room to secure the airway so she can get out of the ICU. And after extensive discussion with the family, they decided they did not want her to die that day or next few days. So they agreed to bring her to the operating room. Luckily, she was intubated. Because if she was not intubated, you could lose this patient while intubating in the operating room. As a matter of fact, all anaplastic thyroid cancers who get airway security, we tell them we may lose them while doing the tracheostomy also. So we brought her to the operating room, made a very high incision, found the thyroid cartilage, and did a trichothyroid. She lived for about 7 weeks. Initially, she lived in the hospital for a while, and then in the hospital, nursing home, and eventually died. So, am I happy about giving her 6-7 weeks? I don't know that. I don't have the right answer. There is a huge debate in the anaplastic thyroid cancer guideline to do the tracheostomy or not. And the consensus is no prophylactic tracheostomy. Do the tracheostomy when you want the patient's life to be prolonged by a few days, or a few weeks, or there is an emotional need for the family to understand that my mom is going to die. There was a professor of physics that I did a tracheostomy, and my entire department got mad at me. And their answer was, you should not have done tracheostomy, you should have told the patient, spend time with the patient and tell them that they're going to die, I'm going to die. I said the family was not ready to die. And he lived about 3 months after that with the tracheostomy, and he wrote me a note, because we had discussed this with the family. He wrote me a note, the last 3 months that you gave me were the best time of my life. because that's the only time I could tell my family how much I loved it. And that was so, touchy to me that yes, these are the difficult problems, but do the best you can.
So, with the change in the guidelines of minimally invasive, can't follow thyroglobulin any longer. So endocrinologists now are following it with repeat ultrasound.
Right.
And every little nodule, because the opposite lobe will have nodules,
Right.
needle biopsies and repeat ultrasounds. I think patients do not want to be restuck multiple
Correct.
times.
Yeah.
I mean, in my practice, I feel like it's very difficult to convince patients who have nodules on the other side not to have a total thyroid.
Yeah.
And they are going to keep getting ultrasounds and have their neck, when they're getting an ultrasound, the neck nodes adjusted and you keep getting these consults back. So any
Okay, so
recommendations?
our philosophy is when you operate on the patient for a unilateral thyroid pathology, okay, so there is a 3 centimeter cancer on the right side. Make sure you have got a good ultrasound that the opposite side is normal. If it is not normal, there is a nodule more than 5 millimeter, I would do a total thyroidectomy treatment. Because if you don't do it, what is going to happen is that 5 millimeter nodule on the other side is going to haunt you. She will come back with a 1 ultrasound, the 5 millimeter becomes 7, she is going to alarm, and she is going to say, I want surgery. So if there is now, why we don't do below 5 millimeter is a negligence. Nodules below 5 millimeter are about 50% of the American people have it, so we don't do that. But more than 5 millimeter, I would do a total thyroidectomy. That's our general philosophy. If in the follow-up you see a tiny nodule, we would evaluate it like any other nodule, not rushing into the biopsy. One of the problems of needle biopsy is when the needle biopsy is done and comes back as atypical, you are stuck. You have to operate on it. So try to avoid. And one of the good thing about thyroid surgery is if you as a surgeon has a backup of your endocrinologist and it's a one voice, it helps a lot. Half the references we get at Sloan Kettering are not because we do something different, but there has been a dichotomy of opinion between the surgeon and the endocrinologist. Luckily, we work together. We have philosophy. We have anytime there is an opinion to be given to the patient which is going to be controversial, we won't give. We say, I'll call you tomorrow. Let me talk to my endocrinologist. Let's make sure that we are in the same wavelength. And that helps quite a bit.
One last question. You normally don't send FNAs for Afirma if it's Bethesda 1, 2.
Yeah.
But we have had cases where somebody outside the
Yes.
institution is sent it for Afirma, and so it's normal, but the Afirma comes back suspicious.
Suspicious, yeah.
What would you do in that case?
Yeah, that's a good question. Actually, there is a debate at the AHNS meeting which I'm talking on. So what she's trying to say is, when the needle biopsy is sent for molecular testing or GEC, and it comes back as suspicious or positive, what do we do? You have to sit with the patient and tell that the risk of thyroid cancer in a nodule is about 5 to 10%. You take any thyroid node. With the Afirma positivity, your risk slightly goes up. But in my heart, I'm not convinced based on the ultrasound, based on my finding. At the same time, there is no way I can rule out papillary microcarcinoma unless I take out your thyroid. And nobody can rule out papillary microcarcinoma in my thyroid unless somebody takes it out. If you explain that to the patient and tell her that, look, I'm going to marry you, you will be with me for the rest of my life, I'll see you every 6 months. If that works out well, we'll follow it. If that does not work well, you're not sleeping on this, you think that my cancer is coming out of my little toe, take it out tomorrow. If you explain this to the patient, I think they're quite comfortable. I'm not convinced with the word suspicious in Afirma reporting. They use the word suspicious. They should use the word GEC positive. The minute you use the word suspicious to the patient, it is suspicious. There's a big difference in telling your test is positive and your test is suspicious. So I don't like that word, and this is my public comment to their company also, that they should not use the word suspicious. Suspicious means the patient needs operation tomorrow. And that's not true. We have found several false negative or false positive FRMA. So I go with the clinical Hashimoto. FRMA will be always positive. Atypical nodule, it will be positive. So we don't use that as a face value. We use that with the whole clinical scenario. And we are very comfortable. You know what has not been used in the United States, unfortunately? TIRADS. You know, the thyroid sonography evaluation system. Just like the Bethesda system for cytology, there is a TIRAD 1, 2, 3, 4, 5, which is very popular in Southeast Asia, and they use it more often than any of other tests. And they are more successful than us. My hands can give me a confirmation of malignancy in 50%. The FRMA gives in 40%. So what is better? My hands, my thought process. But unfortunately, when the report comes back as suspicious, the patients want to push for surgery. They have no choice, you know. And that's a dichotomy between the investigation and the treatment. Many times, you know, I always use one indication, strong indication for thyroid surgery, and that is anxiety. There is no treatment for anxiety. The only treatment for anxiety is surgery. Okay?
Thank you so much.
Thank you very much.